Thanks so much. I'm really excited to be here and to talk about this topic that is really important and interesting to me, and hopefully to you too. There we go. I have no disclosures. So obviously there's many controversies in abdominal wall hernia repair, which is the purpose of this session today. And we've heard about a lot of them already today, but there's a lot of questions that arise about the best surgical approach, whether or not to use mesh, what kind of mesh to use, where to place it. What do we do about very small hernias? But interestingly, a question that comes up quite a bit is what do we do about hernias in females? So, half the population, a large proportion of our patient population, there's a lot of questions about what should we do when fixing ventral hernias in women of childbearing age? How do we deal with the increased pain after different types of hernia repair? And a big place where this comes up, and what I'm going to spend most of my time talking about today, is how we think about groin hernias in women and why it's such a problem. So I think stepping back a little bit, it's important to understand kind of the roots of why there might be controversy in this field to begin with. So I think at a global level, we know that not just for hernia, but for many diseases, cardiovascular disease, when you look at limb salvage procedures, outcomes after MI, there are significant biological differences in the response to disease and treatment between males and females. And at the same time, females have historically been excluded or underrepresented in many different important trials and studies, initially kind of for ethical reasons, and now I think there's a lot of bias in who's affected by disease. And as I'll show, females are significantly underrepresented in hernia research, which I think leads to a lot of the controversy that we see. So like I said, I'm going to spend most of my time talking about groin hernia repair. One of the challenges with this disease is that it's typically thought of as a very male-centric disease. And it is true that it's much more common in males, so we know that at a population level, about 1 in 4 males will have a groin hernia repaired during their lifetime, and there's about 700,000 performed in the United States every year. Considering females, it's quite a bit lower incidence, but still not insignificant. 6% of females will have a groin hernia repair during their life. And when we look at all of these operations in our country every year, women comprise more than 10% of that population. But when we look at all of the really important seminal trials that have informed not only our practice in terms of surgical approach, but whether or not to operate at all, we see that women or females are significantly underrepresented. So in only one of these 5 clinical trials were females included at all. And you can see at these really important studies that we saw, there's just no inclusion of women. So we have over 20 years of really well-funded, well-done research, nearly 4,000 patients, but fewer than 0.5% were females. And if you remember the previous slide that I told you that 10% of patients that get a groin hernia repair are females, we're having a significant mismatch here. And I think the question is like, well, is this a problem? Isn't it a groin hernia just a groin hernia? The big problem is that females actually have really a lot worse outcomes in many different domains, and I'll kind of go through these, but we see worse outcomes in terms of the clinical outcomes, significantly more chronic pain, and then even looking at some more novel patient-reported outcomes, we see worse outcomes. So operative recurrence, it's typically thought of as kind of the gold standard of whether your operation worked or not. Is the hernia going to come back? And we know from a lot of studies that females have a higher risk of operative recurrence. This figure is from a meta-analysis looking at several 100,000 patients and showed that females were significantly more likely to have operative recurrence. So, the treatment's not working as well for them as it is for males. Looking at other kind of more short-term clinical outcomes, this is from a study that our group did looking at post-acute care services. So shortly after surgery, what's happening, we looked at over 37,000 patients who had elective groin hernia repair. Again, about just over 10% were women, which kind of fits with what we know about the epidemiology. But when we looked at the cohort of patients who utilized post-acute care services, so physical therapy, need for acute rehab, things like that, females were significantly overrepresented in that cohort. And even after adjustment for patient characteristics, operative details, et cetera, we again found that males were significantly less likely to use post-acute care services. So we can see that in these clinical outcomes, both in sort of long-term metrics of did my operation work, as well as short-term, how do patients do after surgery, females are really doing quite a bit worse. Chronic pain is obviously something that sort of we all worry about, I think, regardless of the sex of our patient. But many studies have shown that females have an even higher incidence of chronic pain following groin hernia repair. So this figure is from a recently published paper where they looked at outcomes of a population-level cohort of patients who had undergone groin hernia repair in Sweden. Females are represented on the left-hand column in the dark gray, and you can see that at 12 months, females are significantly more likely to report pain that impairs their function, as well as severe pain. And when they followed this patient population out at up to 5 years, these differences persisted. So at 5 years, females were much more likely to report pain of any intensity and moderate to severe pain. And finally, like I mentioned, we're looking at some novel patient-reported outcomes to help us understand how well we're addressing our patients' problems. And one of these is decision regret. And for those of you who aren't familiar with this, it's a metric that basically asks the patient, do you regret having your care? And while it may not be as helpful for emergent conditions or oncologic procedures, it's really useful for preference-sensitive conditions such as hernia repair, where there's choices about whether or not to have your hernia repaired, how should you have it repaired, the timing, things like that. And this is some pilot work that we're just starting to look at, but we again looked at over 4,000 patients who received post-operative surveys up to 90 days following their operation. And even after adjusting again for surgical approach, patient characteristics, females were significantly more likely to regret that they had at least some degree of regret for undergoing their operation. And so I think, anytime we see these significant clinical differences, it then leads to ask, well, what is driving these differences? And I think, there's a couple things that could be driving this. One is obviously surgical technique. Another is patient selection. Are we picking the wrong patients, or should all females have their groin hernia repaired? Or, there may be something else entirely that, just we haven't discovered yet. Thinking about surgical technique, when you look at MIS, so TEP, TAP, robotic versus open techniques, although I think, we each, there's conflicting data, there's probably some degree of equipoise for males, at least for the unilateral hernia. But we do have evidence to say that on the whole, MIS is really preferred for females. And one major reason for this is that the type of hernias that females have is quite different than males. So females have a much higher incidence of femoral hernia compared to direct or indirect inguinal hernias. And those are obviously detected much more easily from a minimally invasive approach. And then we also know from some registry-based work that MIS for females is probably associated with fewer complications, a lower recurrence rate, again, because we're catching more of those femoral hernias at the first go, and less pain. So then the question is, are females actually getting this approach that we think is better for them? We know that at a population level, the penetrance of MIS groin hernia repairs is not great. So this is a nice figure that one of my colleagues published a couple years ago looking at MIS groin hernia repair in Michigan. And you can see that for most regions, the minority of patients are actually undergoing an MIS hernia repair. So we then said, well, females should be hopefully maybe at least as likely to get an MIS hernia repair as a male, or hopefully more likely, because we think that this is the better approach. And again, this is some pilot work that we haven't published yet, but again, looking at a cohort of over 20,000 patients, we found that females were actually less likely than males to get an MIS hernia repair, even after adjusting for important patient and operative characteristics. And so our conclusion was we have this evidence that this might work better, but most females are not getting this approach. So it really could be, one driver of these poor outcomes. The second question I think is really controversial is what do we do about watchful waiting in this population? So we know that it's totally safe for males, even though most patients will end up getting their hernia repaired at some point in the future. But it's really never been studied in females at all. And as they have been from most studies in hernia, they were excluded from prior studies. I think for a number of reasons, but the big one being this concern for femoral hernia. And we know that femoral hernia is more common in females. And so there was really concern that, it's not ethical to randomize patients to watchful waiting. But, when we look at how we developed this strategy for male patients, we all know about this landmark trial that was published about 15 years ago that really proved that watchful waiting was not placing patients at increased harm. But prior to publishing this trial, they actually published kind of a protocol of the trial to say, this is why we're doing the trial, this is how we're doing it. And in that trial, they really had to motivate the study. And, they said at the beginning of their paper, we're really taught that the surgical dogma was that you have to repair all of these hernias because there's this high risk of incarceration. But we really need to do this study because we have no modern data to tell us what that risk actually is, because most of the data at that point that was informing the risk of strangulation was very old case reports, things like that. Interestingly, when you look at the guidance for why watchful waiting is not recommended for females, it sounds very much like this motivation for why they had to do this study in males. So you look at the guidelines and they say, it's too high risk, there's too much risk of strangulation, but there's really no data driving our practice. And when you compare what they had to use 15, 20 years ago to motivate this really practice-changing work versus what females are still contending with today, it's really, this surgical dogma that's never been challenged, as well as a lack of data driving their care. So again, I think the big question, why do females have worse outcomes? We don't know for sure. It's probably some combination of the surgical technique, that they're not getting the appropriate care. Potentially there's a role for not repairing all hernias, and then really thinking, are there other metrics that we haven't even quite hit on yet? And I think for this specific problem, what I would really love to see is a pragmatic trial that really starts to answer a lot of these questions by including a really diverse group of patients, asking them what's important to them, really understanding how our different real-world practice patterns affect outcomes. But I think that this is specific for this problem, but I think the question is, what do we do kind of like at a more global level throughout all of our work in hernia? And this is a figure that I draw on a lot. It's from the NIH, and it's really driving home the importance of thinking about sex as a biological variable in your work. So not only when you're making up the final tables for your paper, but at the very outset when you're designing your study, really thinking about how might these outcomes or this intervention affect the different sexes? How are you going to build that into your study? And how you might, analyze that and report that out to really make sure all of our patients are getting the most appropriate and the best care that we can offer them. So with that, I'll end, but thank you so much.